So I am happy to introduce our presenters today. Dr. Solomon Giwa is an assistant professor and associate dean of undergraduate programs in the School of Social Work with a cross appointment to the Department of Sociology, Police Studies at Memorial University. And he's the endowed chair of criminology and criminal justice at St. Thomas University and is an anti-racism, equity, diversity, and inclusion trainer and consultant. His research interests are in the areas of race and sexuality, LGBTQ plus migration, settlement and integration, and intersectional LGBTQ plus stigma and human rights. Dr. Giwa serves as a convener for the Research Exchange Group on Gender, Sexuality, and Health at the Newfoundland and Labrador Center for Applied Health Research. With him today is Charlie Murphy. He goes by the pronouns he and they. He's the executive director of Quadrangle, Newfoundland and Labrador. And for the past 12 years, he has worked for the community through a number of organizations like PFLAG St. John's chapter as peer support facilitator, a former board member of the local Pride organization, St. John's Pride, a past president of Planned Parenthood Newfoundland, and a co-founder of Raise Up Fundraising, a non-for-profit organization that raises funds and awareness for marginalized populations. He is the Newfoundland and Labrador representative for the Enchant Network and is currently also working at the St. John's Regional Support Coordinator for the Community-Based Research Center. So I am going to turn off my video and I hand over the rest of this education session to our presenters. Thank you. You guys can go ahead.
Awesome. Thank you so much for the invitation. Is it okay? Do you prefer that I'm on camera or off camera? Is there a particular protocol that you're following?
Does not matter to me. It's up to you. You can be off camera if you want.
Okay, so good afternoon, everyone, and thank you so much for coming. I want to begin by offering my sincere thanks to the College of Registered Nurses of Newfoundland and Labrador for organizing this event and also extending an invitation to both Charlie and myself. It's wonderful to be here with you. I also want to kind of begin by acknowledging the land on which I am situated at the moment, which is the traditional unceded territory of the Algonquin Anishinaabe people who have lived on this land since time immemorial. I'm also grateful to have the opportunity to be able to be present in this territory. With this acknowledgement, I also want to kind of underscore that settler relationships about the land and the peoples of this land have been broken and misused. And part of my commitment is to prioritizing individual and collective commitments to challenge and also to dismantle white supremacist colonial mindsets, which we have internalized both collectively and individually. So for today's presentation, I am working under the assumption that for some people in the audience, this might be your first time learning about LGBTQ plus people. I have also kind of assumed as I was putting together the presentation that others may also have some or greater understanding about the population, but perhaps not in the context of today's presentation. So for our time together, what I'm hoping to cover are, the issues around LGBTQ2S plus acronym and the context of those acronyms, to reflect on social determinants of health and how that is also kind of tied to health issues that LGBTQ2S plus populations might face. What are some of the barriers to healthcare? And then what are some of the facilitators to healthcare? So many of you in the audience may be aware of the acronym LGBTQIA2S+. And however, it is important to know that variations of the acronym also exist. So that depending on the space you're kind of inhabiting, you may actually hear different terminologies or acronyms being used by different people, such as LGBTQ. The choice of acronym, however, may be motivated by different factors, including expediency. So given that the acronym can sometimes get very long. So for example, you may have also kind of noticed me at the beginning using LGBTQ2S+ instead of LGBTQIA2S+. The plus at the end of the acronym is actually very important as it actually signals an attempt to be inclusive. So another frequently used acronym albeit in international human rights context, is SOGI-esque, which really stands for sexual orientation, gender identity and expression, and sex characteristics. I guess the bottom line is that different acronyms or terminologies are used by LGBTQ people and non-LGBTQ people for different reasons. And we can think of these acronyms as sort of like umbrella terminologies or concepts, which help people to actually have words and meanings so that they can actually relate to one another. It is important to situate our discussion about LGBTQ2S plus Canadians within the evolving social, cultural, and political landscape of Canada. So you might be aware of the fact that during the early colonial period, sexual intercourse that involved anal and oral copulation was punishable by death. And since the 1960s, LGBTQ plus people saw steady gains in their rights, and this began the liberation of Canadian laws and attitudes. This series of progress actually culminated in the legalization of same-sex marriage, which we saw in 2005. At the time, Canada was actually the fourth country in the world to actually legalize same-sex marriage after the Netherlands, Belgium, and Spain. A little over a decade later, in 2017, and after tireless advocacy by trans activists and allies, changes were also made to the Canadian Human Rights Act and the Criminal Code, which effectively recognized the protection of gender identity and expression. For folks who are not aware of this, these were actually monumental changes that were happening in the context of Canada, particularly because these changes served to bring LGBTQ2S plus people towards mainstream acceptance. When we are considering the experiences of LGBTQ2S plus Canadians, it can be hard sometimes to kind of figure out who or how we're talking about this particular population. Part of the problem stems from the lack of data that is available about this particular population or demographics. And though efforts are currently being made mainly by Statistics Canada, as you'll probably see later on in my presentation, that there's a lot of conservative efforts being made to actually be more inclusive and to make sure that we have enough data that can actually speak to the experiences of this population. But again, despite these efforts that are being made, I think that depending on the sources that you're consulting, you may actually get different estimates about the size of the LGBTQ2S plus population. And what this actually points to is that without robust data and sustained data to actually inform and kind of guide decision-making, the unique experiences and needs of LGBTQ2S plus Canadians will continue to go unaddressed. So from available Statistics Canada data that we have, it actually suggests that about 1 million Canadian, or 4% of the population age 15 and older, identify as LGBTQ2S plus population. So we're steadily seeing the inclusion of the LGBT population within data that are actually emerging. And increasingly, we're getting a sense of the breadth and the depth of that particular population. From the combined 2015 and 2018 data from the Canadian Community Health Survey, we also find that when we're looking at the concentration of, or the population of gay men, that they actually come to make up 255,100 of the LGBTQ2S plus Canadian population. When we're thinking about the lesbian women, they are enumerated to be around 150,600. Bisexual women make up 332,000, bisexual men 161,200, and trans non-binary accounted for 75,000 of the population. Again, with respect to the trans and non-binary, it is worth mentioning that again, Statistics Canada is doing a lot of innovative work around trying to get a better sense of the trans and non-binary population in Canada. Some of the data that they've been relying on have not necessarily allowed them to be able to tease out the specificities of that particular population. But with 2021 census data that they're actually populating, we're hoping to better get a sense of that demographics. Also from available data, we know that 30% of the LGBTQ2S plus population in 2018 also comprised mainly of youth ages between 15 to 24. So there is an increasing representation of LGBTQ youth within the broader population of Canadian society. However, when we look at the older populations of LGBTQ folks, what we see is that there's actually a smaller number of them compared to the same demographics of non-LGBTQ plus population. So here we have 7% of LGBTQ2S plus population of Canadians in 2018 were between the ages of 65 and older. It is also worth noting that Statistics Canada began collecting data about same-sex partnerships in 2001. And over the years, the number of same-sex couples compared to opposite couples have increased by 60.7%. So although more LGBTQ2S plus people are reported to be in common law relationships, the number of married same-sex couples also seems to be on the increase. So if you can see on the table there that, you know, over the same period of 2006 to 2016, there was a 60.7% compared to 9.5% of opposite couples in relationships in Canada. But then you can also see that, you know, over the same 10-year period, the rate of same-sex couples also kind of increased to like 33.4%. But when we look at the numbers in relationships to common law status, we actually see that there's a greater number of LGBTQ2S plus people who actually identify as being in common law relationships rather than being married. Also from available data, we also see that the migratory and settlement patterns of LGBTQ Canadians, more than half of same-sex couples in 2016, for example, called Toronto, Montreal, Vancouver, and Ottawa Gatineau home. To some extent, this is actually not surprising, given that the range of support and services that LGBTQ2S plus people might need are generally concentrated in this part of the country. So in a province like Newfoundland and Labrador, this has implications for the growth and retention of LGBTQ2S plus population. In essence, if we don't have the kind of support and services that they need, the likelihood of migration is also increased. One of the other advancements that we've been seeing in LGBTQ2S plus rights pertains to the adoption of children. So once again, we are seeing more LGBTQ2S plus populations choosing to become parents and also to raise children of their own. So 12% or 1 in 8 same-sex couples had children living with them in 2016. And what we also see is that when it comes to LGBTQ2S plus Canadians, they report lower average annual incomes compared to the non-LGBTQ2S plus Canadians. So a difference of $39,000 versus $58,000 on a yearly salary. Internationally, Canada is also regarded as a leader in LGBTQ2S plus rights. And by and large, Canadians also enjoy a positive reputation as being friendly, tolerant, inclusive, and accepting of difference. Yet in 2019 alone, over 260 LGBTQ plus hate crimes were reported to the police. This amounts to a 41% increase from police-reported hate crimes in 2018. What this data suggests is that despite the steady progress for formal legal equality that I kind of alluded to earlier, more work needs to be done to kind of eliminate hate targeting people for their sexual orientation and gender identity or expression. And this kind of brings us to the conversation around social determinants of health and why this is important. So you may have seen from and as I hope that the presentation so far has demonstrated, it is not enough just to cursorily kind of acknowledge that a group exists and that they may be marginal in terms of their status within the Canadian society. But it also points to the fact that our efforts must equally be guided by a social determinants of health model, in which we focus on equity, where we can actually help to shine light on the obstacles and barriers that certain segments of the population actually face, in order that more attention and resources can be made available to this particular population and to help them achieve the same level of health and well-being as others. So many of the factors and the dynamics that I've been kind of showing you and walking you through are actually pointing to some of the challenges that LGBTQ2S plus population encounter in Canadian society. And in the absence of a social determinant of health factors or consideration where we are attending to some of the challenges that might predispose them to risk, then we run the challenge of actually not being able to meet the health needs of those population in a meaningful way. And this also has implications for lifespan and intergenerational kind of well-being. So it's really, really important that we pay attention to those factors. What we can also make sense of is, particularly when we look at this illustration here, is that as you can see on the right-hand side, actually across both illustrations, but most on the right-hand side, is that none of the figures has actually changed in terms of the representations of individuals there. Nothing is really changing that. The only thing that has really changed is in terms of just our focus, in terms of the resources, our approaches, the policies, and the practices that we want to focus on. So when we're thinking about equality and equity, this is really what we're talking about in terms of the shifting of focus on resources, approaches, and policies. That if we create opportunities and attend to specific needs that people have to be able to actually live healthy, then we can begin to ensure that we're working towards equity. So that's what you see in the right-hand side around the different levels of the barriers that people are able to kind of stand on. That it actually creates a balance, a sense of equity at the end of the day, in the sense that we're still meeting people's needs where they're at, and we're providing the kind of support and resources that they need to be able to achieve that level of equality. But on the other end, on the left-hand side, when we think about equality, the idea of just treating everybody the same sometimes runs the risk that we actually leave people out, right? So again, when you see there that everybody has the same kind of platform to stand on, but clearly some people are kind of at a disadvantage because of the fact that maybe they're younger or they're shorter, and so on and so forth. So it's really, really important that, again, as we're thinking about the social determinants of health, that we kind of relate it to conversations and discussions around equality and equity, and how we can actually use those lenses as a way to ensure health for everyone. Also, when we're thinking about particular populations within the LGBTQ plus communities, and when we're thinking about it in relationships to the Canadian Community Health Survey data and other studies, what we also see is that LGBTQ people, LGBT, lesbian, gay, bisexual people specifically, were more likely to actually visit mental health services providers than heterosexuals. And I guess we can, deduce certain kind of implications for why that is the case. And also too, we see that lesbians have lower rate of using family doctors, and also that lesbian and gay and bisexual people perceive less equitable access to healthcare and social services, and also report higher unmet health needs compared to heterosexual people. So again, as we're having this conversation, I just want you to kind of think back to the conversation we just had around equity and equality and the social determinants of health, because you can see how all of that kind of parlay into this discussion around, lesbian, gay, bisexual people being less likely to, use family doctors, or to more frequently visit, mental health service providers for support than their heterosexual counterparts. So again, all of that considerations need to be kept in mind, particularly when it concerns matters of equity and equality. And when we look specifically at the trans population or non-binary population within the LGBTQ2S plus population, what we also see, and what this illustration actually demonstrates, is that in the solid kind of like, fuchsia color that you see there, 81% of trans people actually, and non-binary people actually indicated that they had access to a primary healthcare provider. But on the right-hand side, what we see is that within the past year, 45% of trans and non-binary people actually indicated that they had unmet healthcare needs. So that's a significant number relative to the 4%. So I want to kind of pivot a bit to talk about the health issues that we also see among the LGBTQ2S plus population. But I want to begin by kind of talking about the 2019 House of Commons report, which was really sort of like a survey on the I'm trying to get a sense of the health challenges and barriers that LGBTQ2S plus populations and communities actually face. And from that report, we know that LGBTQ2S plus people in Canada experience worse health outcomes than their cisgender heterosexual counterparts, including disproportionate rates of cancer, chronic fatigue, and heart disease. The report also found that LGBTQ2S plus people are less likely to have a family doctor and are more likely to live with chronic health conditions, poor mental health, and substance dependence disorder. Kind of relating that to American studies that we are also aware of, we also know that from those American studies, they found that overall HPV prevalence of 93% and 64% prevalence of high-risk HPV strains among the LGBTQ plus population. In another study, pooled anal cancer incidence was also 45.9 per 100,000 HIV positive men who have sex with men, and 5.1 per 100,000 among HIV negative men who have sex with men. So compared to 2 per 100,000 in men overall. So again, we see continuously, whether it's in the American studies or in Canadian studies, that members of this population continue to be at greater risk than their heterosexual counterparts. Some of the other health issues that we see relate to mental health disorders, where we know that there is a higher incidence of mental health disorders such as anxiety and depression among this population. We also see higher prevalence of eating disorders among gay and bisexual men compared to heterosexual men. We also see overweight. When we're thinking about overweight or obese, we see that among lesbians, there is a more likelihood of them being overweight or obese, which then also increases their likelihood for cardiovascular disease. There's also the increased risk for certain cancers, which may go unrecognized. So the risk of cervical cancer, for instance, may be underestimated among lesbians. And for men who have sex with men, anogenital cancer is also an important concern. So history of anal intercourse and STIs are risk factors for this consideration. We also know, and this should not perhaps come as a surprise to folks, given just the epidemic of the 80s in terms of the HIV/AIDS, that it's also among gay men who have sex with men, they are the most affected group by the disease in Canada. 56% of all cases and 45% of all new infections actually are within the gay male population. Studies of suicide ideation and attempts also suggest that there's an elevated lifetime prevalence for gay, bisexual men and lesbians, and that studies of completed suicides also found no evidence for elevated rates. So there seems to be a mixed result when it comes to evaluations around suicidality and also suicide ideations within the LGBTQ plus population. In terms of STD and STI, men who have sex with men are also believed to be at an increased risk for hepatitis A and B, and syphilis, as well as gonorrhea, chlamydia, herpes, and genital warts and HIV infections. And when it comes to substance tobacco use, gay bisexual men were also twice as likely to be heavy drinkers or abstainers than their heterosexual counterparts. Lesbian and bisexual women also report a higher rate of abstention than heterosexual women. And representative studies of tobacco use suggest that prevalence rate is higher among gay men than in the general population. So obviously, I share all of this information not to create a scenario where we're thinking about LGBTQ plus population only in deficit terms. But I think it's really, really important as we try to understand and better understand the needs of the LGBTQ2S plus population, that we have a general understanding of some of the challenges and the complexities that this population and these individuals have to deal with on a day-to-day basis. And I think this also kind of impacts on their access to healthcare systems. There's an interface between those challenges that they're facing, particularly when we contextualize it within the realm of social determinants of health, that we can begin to tease out some of the added challenges that people encounter that might actually be a barrier for them to actually be able to receive the kind of care that they need. So in preparing this research, presentation, one of the literature that I came across actually spoke to 7 dimensions of healthcare experiences, which really speaks to ways of how we can actually address challenges faced by the LGBTQ2S plus population when navigating the healthcare system. And so we can begin by taking a look, for instance, at existence. And within existence, this is really speaking to the degree to which an LGBTQ plus person actually feels like they are being treated like a human being. So things like nonverbal cues, such as facial expression and body positioning, were some of the things that were identified as the primary sources of individual discomfort. So if you have like a practitioner, for instance, that is not, that is demonstrating nonverbal cues of discomfort, then that was also a signal for the patient to also not necessarily feel welcome, and which therefore can actually be a barrier for continual access to care. Positive healthcare experiences also occurred when the health professional's behavior reflected compassion and empathy, such as the tilting of the head, the direct eye contact, or animated speeches. So again, some of these, tangible ways of, connecting with people are actually mechanisms and ways in which practitioners can communicate to LGBTQ2S plus people that their health actually matters, and that they'll be able to receive the kind of care and support and services that they need by coming to see the doctor or to come to the healthcare facility. By bodily integrity, the idea here is that the level of dignity experienced by patients when healthcare procedures require crossing personal boundaries. So clients have reported a positive experience when healthcare providers were respectful of their vulnerable state and explained every step before or during an invasive procedure. So it's just really about the ethics of, respectability around, but bodily integrity, to make sure that the personal boundaries of patients are being respected, and that patients are being provided, are communicated to in terms of the different activities and different processes or procedures that have been undertaken by the medical professional. So again, for participants who are, LGBTQ identify, they saw those instances as evidence of their rights being respected by the medical professionals. When it comes to emotional integrity, this is really relating to the idea of perceived safety by patients when disclosing information to healthcare providers, and whether concerns and feelings are being validated. So, for instance, when the client is, for instance, coming out, the acceptance of identity by their medical professionals, and also one commonly reported barrier has to do with healthcare for LGBT people who were coming out and experiencing discrimination from their providers. So stress arising from the situation made them emotionally vulnerable, just because of the fact that they were in situations where they did not necessarily feel a sense of reassurance or a sense of acceptance by the medical professionals. Worth has to do with the idea of patients feeling valued during their healthcare experiences. So things like addressing daily discrimination and internalized stigma, which may lead to LGBTQ2S plus people or patients feeling that, to see themselves as unworthy or of not, unworthy of actually receiving help or support from the medical professionals. So again, there is this kind of dynamic process that is happening between worth and also the emotional integrity piece, that they're closely related in terms of helping to ensure that patients actually feel a sense of place, a sense of belonging within the helping process of within the actual process of receiving support and care from the medical professionals. So again, this notion that patients want to feel themselves as being worthy of actually receiving support and care is really, really important for their sense of worth. And this kind of brings us to the notion of uniqueness, where patients' individuality and diverse life experiences are being recognized. So there's this question of whether or not medical professionals actually recognize the individuality and the diversity of the life experiences of the patients that they're actually interfacing with. And do they actually see them more than just their sex, their gender, their sexual orientation? And if assumptions or offhand judgments are being made based on queer stereotypes, or if these experiences with healthcare professionals were reported as being negative. So again, there is this kind of critical interrogation of medical practitioners and people who work within the medical profession to ensure that they're actually meeting clients where the clients are at, and that they're taking into considerations the patient's individuality, the diversity of their lived experiences as a way to ensure that the kind of medical support and services that have been rendered are ones that actually meets the needs of those individuals. Expression kind of relates to the idea of degree of comfort that patients might feel when expressing themselves and their thoughts and their concerns to the medical professional. So this is kind of also related to emotional integrity. I guess the difference is that there's an emphasis being placed on the assumption made by health professionals. So for instance, they may make assumptions related to whether or not a patient is straight or gay, or lack gender neutral language to actually be able to address the particular patients that they're providing services to. And then the final one has to do with power. So what is the power relationship essentially between the provider and the patient? Is it one where the patient actually has a power in terms of helping to also shape the kind of care that they're receiving? Or is it just a unidirectional kind of a care relationship where it's just the provider dictating to the patient the kind of care that they think that the patient should be getting? So again, here we're interested in trying to understand how we can leverage power both on the practitioner side, but also in the sense of recognizing the power that the patient also have to be able to have a sense of autonomy about an agency, about the kind of services that and medical services that they're actually receiving from their practitioners. So those really are the 7 dimensions of healthcare experiences that I think can also be helpful in trying to understand some of the challenges that LGBTQ2S+ people might actually face when it comes to navigating the healthcare system. We can also begin to think about some of the barriers that LGBTQ2S+ population might also face when it comes to accessing care, in the sense of thinking of, particularly here when we're thinking about emergency rooms as an example, for instance, so we know that couple of situations related to actual or anticipated discrimination, for instance, might be one of the ways that LGBTQ2S+ patients, for instance, might experience barrier to healthcare. So here we're really kind of thinking about some of the knowledge and the attitude of providers. LGBTQ patients are, for instance, reported that a lack of provider education is one of the barriers to accessing medical care. Many have reported mistreatment, verbal abuse, and also refusal of care by providers. And when it comes to transgender patients, we found reports where there's been documented cases of overt experiences with discrimination, including gender insensitivity, displays of discomfort, denial of services and substandard care, and also verbal and physical abuse and forced placement into psychiatric facilities are all instances of harm that have been done to members of the LGBTQ2S+ population, particularly when it concerns actual or anticipated discrimination. A recent study in Ontario also found that half of transgender ED users, emergency room users, who presented in their preferred gender, reported negative experiences mostly related to offensive language or being told by the provider that they were unable to provide care to them because they lack knowledge of the needs of that particular patient. So more than half of the transgender ED users also had to educate their provider about their transgender concerns and needs. So the study also found that 21% of respondents avoided the ED because of these negative experiences. So for all the reasons that I just kind of articulate here, we can see again how, even just the expectations or the requirement that the patients educate the practitioner about their needs can actually create a barrier to patients coming back or even utilizing those kind of healthcare services in the future. When it comes to scarcity of provider, we find in the literature that little or no access to LGBTQ-friendly healthcare providers in certain areas can also be a barrier for not receiving support or foregoing care completely. And we can definitely see this particularly in situations where you have to travel long distances to receive services, and in the remote or rural communities, for instance, where there isn't availability of health practitioners that can actually provide the kind of level of care that is needed. These are all, again, instances or barriers that can actually prevent people from seeking support and seeking the kind of services, timely services that they actually need. Reluctance to seek care kind of also dovetail against towards the last point that I just made. Here on a nationally representative level, in terms of the survey that was conducted by the Center for American Progress in 2017, they also found that LGBT people who had experienced discrimination in the past year were also 6 times more likely than those who had not experienced discrimination to avoid going to a doctor's office. So again, we see this recurring theme of how there is a barrier being erected for people so that they're not able to actually get the kind of care and support that they need as a result of just now feeling like they have someone that they can turn to that will be able to provide those services to them. And when it comes to assumptions, 5 common assumptions by provider about gay and lesbian patients that also creates barriers to effective communication and care. So these include assumptions about patient's sexual orientation, sexual behaviors, family structure, role of significant others and family in the person's healthcare, and the effect on messages sent through the healthcare practice. So we see, based on those assumptions, that again, depending on where that individual is at in terms of their healthcare seeking practices, that they may likely not come back to actually receive support and care that they need. Because again, there's this belief that the practitioner actually hold on to assumptions that may not necessarily have any context or any reality to that person's lived experiences. So again, we need to be mindful about some of the assumptions that practitioners also hold, and that can be a barrier for people accessing care. And then there are other barriers that in the US, in some of the US studies that I looked at, LGBT persons experiences barriers to accessing health insurance, for instance, including health insurance coverage. And as a result of these challenges, they may actually forego care due to costs. And racial status, education, income level, immigration status, and also known cultural kind of challenges that we see as barriers to people actually kind of, again, seeking out the kind of support and resources that they need to be able to support their health and to live healthily. So I've been kind of quickly discussed some of the barriers to healthcare, some of the barriers to healthcare for LGBTQ people. I want to kind of also focus on some of the facilitators that we know are positively encouraging people to seek healthcare. I think it's important to understand both dynamics. So here we can definitely see that when we create safe towards LGBTQ positive spaces, this can actually facilitate people coming into those spaces to be able to uptake services and use the facilities and the resources and services that are available, right? So creation of a safe gay positive space free from violence and discrimination can actually support LGBT persons to feel that they can be safe in those spaces. So that's one of the key findings from literature around what are some of the facilitators of uptaking healthcare. We also know that the development of trust in relationships and respect of privacy during service delivery is also critical to people's ability to feel a sense of, wanting to again use or to make use of healthcare services. So here, the relationship between the practitioner and the patient is really, really important, because in the absence of the trust, then there is no real sense of safety there for the particular patient to actually feel that they can actually disclose themselves and disclose issues to their practitioners. So the development of trust is really, really crucial in that relationship. And practitioners must be able to demonstrate that they actually respect the privacy of those patients during service delivery. Anti-discriminatory health policies is also another way that we can ensure that this is also being taking place. So, for instance, the creation of health policies at the government level, but also at the institutional level. And by the institutional level, I'm specifically talking about healthcare facilities and institutions, right? So even the creation of anti-discriminatory health policies at those levels can also be very helpful in terms of addressing some of the systemic barriers that actually prevents people from, coming to the hospitals or coming to healthcare facilities to be able to uptake those services so that they can actually advance their own health. So creating anti-discriminatory policies can maybe support us or move us towards that direction where we are creating policies that are inclusive of everybody and also speak to notions of equity in terms of making sure that people who need the services are actually receiving the services that they need. And then tied to that is also the idea of cultural competency or cultural competent care and referrals. So in a review that was done by Mayer and colleagues on integrated comprehensive care for men who have sex with men, they emphasized that culturally competent care based on human rights principles and that also stressed the importance of gathering the appropriate information, are able to provide care and make referrals and develop strong rapport with patients, and therefore maintained routine care such as cancer screening and sexually transmitted infection testing, for example. So by actually devising mechanisms or developing culturally kind of competent care protocol, it actually facilitated the uptake of many other kind of referral point or even information point or even abilities of patients to be able to take, gravitate towards the kind of supports and resources that are available so that they can actually begin to realize their own health in ways that are consonant to the way that they feel. So this is, again, is really, really important. And I think in particularly, even when we think about some of marginalized groups within the LGBTQ2S plus population, for instance, racialized people, indigenous people, it becomes really, really crucial that we develop culturally competent care so that we can make sure that those historically excluded populations are actually having ways and mechanisms that they can actually get their health needs met. So it's really, really crucial. And I think to kind of just leave you with some key takeaway messages, I think one of the things that is important is that the health of LGBT people are affected by a range of social, structural, and behavioral factors. And as a result, LGBTQ2S plus populations have unique health needs that may not be met by existing healthcare services. So, for instance, barriers to LGBTQ2S plus persons accessing healthcare services include some healthcare professionals' lack of knowledge of LGBTQ persons, as I've already alluded to. Healthcare needs or also have negative attitudes towards LGBTQ2S plus population as well. So we also know that LGBTQ persons may delay or avoid seeking services because of their experiences of past discrimination or perceived homophobia within the healthcare system. So again, it's really, really important that we are looking at this issue from a holistic perspective, and that we're beginning to address this in a way that will ensure the full integration of LGBTQ populations within the healthcare within the healthcare sphere. Also, we know that some LGBTQ persons are reluctant to disclose their sexual orientation, which may also mean that they do not receive the appropriate care that they need. And then finally, we know that access may be affected by LGBTQ persons' ethnicity, education and income level, geographic isolation, as I alluded to, particularly with remote rural communities, immigration status, particularly here if you're thinking about migrant workers, and also knowledge and cultural beliefs as well too that might be in operation. Also are factors that could potentially hinder somebody's ability to, to effectively uptake healthcare practices.